Good evening, respected ACS, Asha Madam, DME, DHS, JDME, and all my respected teachers and dignitaries. I would like to thank Indu Madam and Rashid Sir and the PEDSEL team of GMC Kollam for giving me this opportunity. So next 15 minutes, I'll be taking you through the clinical updates and management protocol in leptospirosis. So till now, all our updates, this is the third update, has been focused on means the COVID-19, the treatment as well as the vaccines with regard to COVID-19. Actually, COVID-19 has sort of brought about a paradigm shift in the treatment of infectious disease. So it was in COVID-19 that has been demonstrated that majority of the drugs which has very good mortality benefiting now, the COVID-19 SARS-CoV-2 infection, were not, the antivirus. There were the drugs, which targeted the cytokine storm or the hyperinflammatory response of the host. The drugs with very good mortality benefit were the steroids, the IL-6 inhibitors like tocilizumab, JAK inhibitors like baricitinib, tofacitinib, as well as the anticoagulants. So in this context, I would also like to look at the evidence that we are following with regard to the treatment of leptospirosis through the eyes of COVID-19. A brief update on natural history. We know that following exposure, the infection can manifest in different ways. It could be an inapparent infection, carrier state, or dead end in humans. Can lead to overt clinical illness and anictic leptospirosis in 90%, anictic leptospirosis in 10%, of which say around 5 to 6% might lead to fatality. And when you look at the pathogenesis of severe disease, here it is actually, majority of the infections, leptospirosis, the rickettsial infections share something in common with the COVID-19. So that is actually the endotheliitis and vasculitis that is occurring. So the hallmark of COVID-19 we know is endotheliitis and activation of the coagulation cascade. Here also in leptospirosis, we can see the damage to small blood vessels leading to vasculitis, which could be due to the direct cytotoxic injury or immunological injury. And this results in massive migration of fluid from intravascular to interstitial compartment, resulting in multiple organ dysfunction syndrome. So when we talk about the treatment of leptospirosis, we are referring any textbook, standard textbook on leptospirosis or any protocol. So it says that antibiotics and supportive treatment, and supportive treatment, there is nothing specific. Whereas, the treatment of COVID-19, we have drugs to target all these axes. We have drugs to target this activation of the coagulation cascade, drugs to target vasculitis, etc. So now leptospirosis, the role of cytokine storm, a term which is very familiar to all of us following this COVID-19. So what happens in leptospirosis also following the lepto phase or leptospiremia? So there is activation of the inflammatory response, which might result in dysregulated immune response or cytokine storm, which can result in activation of the coagulation cascade leading to clotting, shock, lung injury, cell death, immune paralysis, renal failure, etc. So all these terms are actually, this immune paralysis, etc., are described in COVID-19 as well, and end result could be death. And why some patients, around 90% of the patients develop mild leptospirosis or asymptomatic leptospirosis, whereas 10% go on to develop severe leptospirosis. This figure is from an article in the Frontiers, and the study was done in the mice as well as the hamster model. So basically what happens is the response of the host to the antigen, that is the leptospira. So there is actually a fine balance between the pro-inflammatory response as well as the anti-inflammatory response. For pro-inflammatory response, in this study, the marker is this TNF-alpha, and for anti-inflammatory response, they use the marker as IL-10. So in patients with asymptomatic or mild leptospirosis, what is happening is that there is a fine balance between the pro-inflammatory response and anti-inflammatory response. Means that there is an early and strictly regulated inflammatory response. This leads to decrease in leptospiremia, kidney colonization in reservoir animals, and so there is no progression to multi-organ dysfunction. Whereas in case of severe leptospirosis, so you can see that the balance is tilted in favor of the pro-inflammatory response. So there is a dysregulated immune response. The INF levels are more than that of IL-10. So this actually leads to multi-organ dysfunction. So this is actually what is happening in severe COVID-19 as well. A subset of patients will develop this cytokine storm, and that is exactly what is happening in leptospirosis also. Mind you, the treatment in COVID-19 to target this is not really antivirus. It is immunomodulator drugs, and that aspect has not been established or has not been explored to that extent in leptospirosis, because it is, as Asha Madam said, it is a neglected tropical disease. We are very familiar with the stages of leptospirosis. Initially, we are having a leptospiremic phase. There is an interphase as well as the immune phase, and majority of the organ dysfunction is occurring in the immune phase. Even though we say that the leptospiremic phase extends to up to 7 days, what the data from Kerala shows is that majority of the deaths are occurring within, say, around 5 days of onset of symptoms. So means that, just like in dengue, etc., there is a fusing of the initial phase, the septicemic phase and immune phase, which is going on in leptospirosis as well. So this diagram is also very common. One thing we should notice that the leptospira has got two protective or replicative niches from which our is protected from our immune response. So the patients can go on having colonization of the proximal tubules of the kidney, and also go on have the leptospira may survive in the aqueous humor as well as vitreous humor, and patients can have uveitis as well as interstitial nephritis for months or years together. When we look at the clinical manifestations, there are it's divided into broad clinical categories like mild influenza like illness or the classical wheel syndrome, characterized by jaundice, renal failure, hemorrhage, myocarditis with arrhythmias. Patient can also present with meningitis or meningoencephalitis, pulmonary hemorrhage with respiratory failure, very important because the mortality associated with this is around 30 to 60%. We can also have hemorrhagic syndrome with acute kidney injury, a situation which is very similar to that of hantavirus infection. And chronic uveitis, one of the common causes happens to be leptospirosis. And this is the initial guideline on the treatment. So when you look up the treatment, it happens to be antibiotics as well as the supportive treatment. It's from the 2003 IDSA guidelines where they were recommending ceftriaxone. Why? Because ceftriaxone and sodium penicillin G were equally effective for the treatment of leptospirosis, but once daily administration and the extended spectrum of action of ceftriaxone against leptospira provide additional benefits, because now if you're dealing with endemic fever, the ceftriaxone will cover. So that was the situation then. And we now know that majority of the antibiotics have very good activity against leptospirosis. Not only ceftriaxone and penicillin, but azithromycin, doxycycline, ampicillin, you name it. So almost all the antibiotics are effective against leptospirosis. And now we say the penicillin is a drug of choice because now is the era of antimicrobial resistance and antibiotic stewardship. So we want a narrow spectrum antibiotic to be used rather than a broad spectrum antibiotic like ceftriaxone. Ceftriaxone belongs to the vast category of antibiotics. So we want to use antibiotics in the access category like penicillin, crystalline or doxycycline. Doxy has got very importance in our situation because initially it may not be very easy to differentiate between leptospirosis and scrub typhus infection, whereas doxy will cover for both. And this is one very, very interesting meta-analysis from the Cochrane group, which came in 2012. So if you go through this, the important aspect is they looked at around 7 RCTs. We don't have enough RCTs to look at the treatment efficacy of antibiotics in leptospirosis. So what the conclusion is that there is insufficient evidence is available to advocate for or against the use of antibiotics in therapy of leptospirosis. So, and when electing to treat with an antibiotic, selection of penicillin, doxycycline, or cephalosporin does not seem to impact mortality nor duration of fever. The benefit of antibiotic therapy in the treatment of leptospirosis remains unclear, particularly for severe disease, and further RCTs are required. So there is a trend towards, which was not statistically significant, means that if antibiotics are used, in the duration of clinical illness may be shortened by around 2 to 4 days. And there was a recent meta-analysis published in 2021 in the journal Pathogenesis. Here also the conclusion is they looked at 10 RCTs, but all these RCTs do have some biases. There is no evidence that antibiotics are a better treatment than placebo regarding mortality, shortening of fever, liver, and kidney dysfunction or reduction in hospital stay. On the other hand, neither doxycycline or penicillin or azithromycin have shown statistically significant differences in preventing symptomatic infection in leptospirosis also. So whenever we talk about leptospirosis or any disease, when we do the mortality audit, but we say that a delay in diagnosis is leading to the death. No, that may be true in the case of H1N1 or say scrub typhus infection, where the early initiation of treatment does make a difference. But in COVID-19, we know that it is basically about starting the right treatment at the right time. That is when hypoxia, etc., sets in. And when we look at the leptospirosis scenario, I think that we need to have a relook at our strategies because the antibiotics, any patient with high-grade fever in Kerala will receive some antibiotic, and all antibiotics are effective against leptospirosis. Still, some patients are dying. That means that we need to focus, along with antibiotics, on immunomodulatory strategies as well, which are not clearly explored in leptospirosis. And this is one study which looked at the predictors of mortality in leptospirosis in Kerala. So hyponatremia, elevated CPK, bleeding manifestations, cardiac involvement, and neurological dysfunction were to be the significant predictors of mortality. And this from the studies from Trivandrum, and the study from Calicut also showed that myocarditis as well as neurological dysfunction are predictors of mortality in leptospirosis in Kerala. What about the role of immunomodulators, steroids? So 4 observation studies showed that the steroids were beneficial in severe leptospirosis. There is only one RCT which looked into this, and the recommendation is that there is no robust evidence to suggest that high-dose corticosteroids are effective in severe leptospirosis, and a well-designed RCT has to be done. So it doesn't mean that it's not going to work, because many observation studies have shown that in severe leptospirosis it does work. But no, the evidence that we garner from observation studies is not enough. We need to have very good RCTs. And now the problem with leptospirosis is severe leptospirosis is, even youngsters who are present with, ARDS as well as pulmonary hemorrhage, the outcome is actually very bad. Mortality is as high as 60%. And majority of the studies which looked at immunomodulators as well as other modalities of treatment like the plasma exchange have come from Sri Lanka. So this is one such study from Sri Lanka which looked at this severe pulmonary hemorrhage syndrome, where they tried this the therapeutic plasma exchange, and you can see that in the group the survival is around 74.5% when this plasma exchange was initiated within 48 hours of hypoxemia. So it's a very early initiation of plasma exchange was found to be beneficial. And there was another study which looked at all the published articles on plasmapheresis and ECMO in leptospirosis, and as of now the current evidence is insufficient to recommend the routine use of plasmapheresis or ECMO. Why the plasma exchange was tried in the Sri Lanka studies was that they found that in this pulmonary hemorrhage is not related to the severity of thrombocytopenia or any change in the coagulation parameters. It's more to do with immune-based injury to the capillaries or capillary endothelium in the pulmonary vessels. That is why they looked at methods to remove the antibodies away. So the therapeutic plasma exchange was tried. And we could not find any study targeting the use of JAK inhibitors or say IL-6 antagonists like tocilizumab, which is being used with very good effect in COVID-19 leptospirosis, and all these things need to be explored. And in 2018, following the increase in number of deaths due to leptospirosis, myself along with Iddu madam did a sort of a mortality audit on around 40 cases of leptospirosis died, and majority of them had fever, myalgia, and headache, and diarrhea was there at around 46%. The most interesting observation was that the time to death from the onset of illness is around 5.65 days. That is, during this period, we thought the access to PCR, you are not going to diagnose the patient as having leptospirosis because IgM is going to become positive only after that. So if you don't have access to, the PCR, all these things are likely to end up as fever deaths only. Okay, so it has to be a clinical diagnosis. And the interesting aspect is time to death from time to admission in medical college was 1.9 days. So in patients who died, they died within 2 days of admission to medical college. We cannot say that it's a delayed referral because anyway from the onset of symptom, patient is dying within 5.6 days. So and the patient is being referred to medical college on day 3 itself. So this is the problem. Those patients who are progressing to the ARDS, etc., the progression is pretty rapid. And this is the role of the doxy prophylaxis during flood. You can see that 96% of the patients who died did not receive doxy prophylaxis. So basically, doxy prophylaxis is something which we need to stress upon, especially not only with regard to the flood, with the high-risk persons like the flood, as NREK workers, etc. This is one strategy which is likely to bring down the disease severity. It doesn't mean that all the studies are favoring doxy prophylaxis because in certain studies, multivariate analysis, when other aspects like the gloves and the gumboots, etc., are accounted for, doxy was not found to have a protective benefit. But whatever experience suggests that doxy prophylaxis is actually a game changer in leptospirosis when administered to the right patient population. This is actually sort of a meta-analysis on the use of chemoprophylaxis after floods to reduce occurrence and impact of leptospirosis. And the conclusion is that the result of this study suggests that chemoprophylaxis may provide some protection in reducing the number of leptospirosis cases after a higher risk exposure. However, the effective benefit may depend on a variety of factors such as timing and coverage of prophylaxis. And this is actually the the guidelines on doxy prophylaxis, which was released in 2018. So the thing that I'm trying to focus is that when you do the death audits, in majority of the patients, NREK workers, etc., Despite advice, they are not taking this doxy prophylaxis. And once leptospirosis sets in certain category of patients, the progression is going to be pretty rapid. So we need to focus more on the primary prevention as well as this doxy chemo prophylaxis. So about the treatment protocol, any patient with an epidemiological link with the clinical features of leptospirosis, coming to the PSC or CSC should be initiated on doxycycline, and they should be assessed for this red flag signs like tachypnea, tachycardia, hypotension, jaundice, altered sensorium, molecular hemorrhagic manifestation. If so, they should be referred to the next level where based on the severity, they should be started on crystalline penicillin, and in case of penicillin allergy, should be switched over to ceftriaxone, or in case of ceftriaxone allergy, go for IV azithromycin or doxycycline. And then we need to do focus investigation to rule out, the complications like the acute kidney injury, or say this worsening jaundice. Need to look for hepatic failure and thrombocytopenia, altered sensorium. Go for CT brain, rule out myocarditis, and epigastric brain, rule out pancreatitis, etc. And we need to rule out other tropical fever syndromes like dengue, malaria, strep typhus, central fever, H1N1, and SARS-CoV-2. And sometimes the multisystem inflammatory syndrome in adults can exactly mimic the Wheel syndrome as well. And from the Taluk hospital, the patient should be referred to the tertiary care centers if there is hypotension which is not responding to the fluid treatment, and if there is evidence of ARDS or progressively deepening jaundice with evidence of liver failure as INR is elevated, and oliguria which is not responding to fluid challenge, and if there is evidence of bleeding manifestations like hemoptysis, emetemus, etc., and if there is alteration of sensorium persisting after correction of electrolytes. In the tertiary care centers, the focus investigation should be done to rule out myocarditis, ARDS, hepatitis, AKI, pancreatitis, myositis, rhabdomyolysis, aseptic meningitis, acaricus, cholecystitis, and DIC. And the most important aspect is that there will be an element of prerenal failure in majority of the patients. And if you're not very sure about myocarditis, the most important aspect in the treatment as far as supportive care is concerned is optimization of the fluid status, and all the secondary and tertiary care centers do have access to ultrasound, and should be the fluid responsiveness should be assessed, or fluid should be administered based on the IVC collapsibility as well as the distensibility index. And then in case of renal failure, the nephrology consultation should be given at the earliest, and this algorithm was created with the help of was created actually by the Department of Nephrology, Trivandrum Medical College. This is a part of the state protocol. That is, the door to dialysis time should be shortened if required at the earliest. And there's a renal dose modification of the antibiotics which are being used in the treatment of leptospirosis. The usual drugs that we are using like ceftriaxone, doxy, penicillin, azithromycin does not require any dose modification. And then another important aspect is those patients with ARDS. If you want to get the patient out of ARDS, we need to have very good ventilatory strategies, and these are also part of the treatment protocol. And the patient is not responding to this usual ventilatory strategies, then we need to consider ECMO as well. In short, we need to focus on the prevention, primary prevention, as well as chemoprophylaxis for the high-risk groups. Then antibiotics has to be administered at the earliest. The supportive therapy is actually very, 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 very important. And the role of immunomodulators, as of now, we don't have any evidence to support the use of steroids or the use of anticoagulation, or also cyclophosphamide or tocilizumab or JAK inhibitors and leptospirosis. But this is one area where very good RCTs should come up, and I think that it's time that we start RCTs on these aspects. So I would like to thank Indu Madam and team for this opportunity. And the need of the hour is actually a recovery trial for leptospirosis, where using the same platform, we should be trying out the different immunomodulatory strategies to bring down the mortality in severe leptospirosis. Thank you, Madam.